Every system is perfectly designed to produce the outcomes that it does. Now, this underscores the importance of analyzing and understanding our existing systems to drive meaningful change. That 2 a.m. emergency, it started weeks ago when we discharged a patient without ensuring that they could afford their medications. I'm Christina. This is Outcomes, where I talk about healthcare finance and business strategy through the lens of social impact. Early last year, I completed the Institute for Healthcare Improvement Open School course on quality improvement. It was incredibly eye-opening. I highly recommend it. The course series covers all things QI, deep dives into the model for improvement, PDSI cycles, and data interpretation. There's actually a free version available on their website. I'm not affiliated with IHI in any kind of way, but I just wanted to share that resource for anyone interested. But one of the biggest takeaways I got from this course was this principle. Every system is perfectly designed to produce the outcomes that it does. Now, this underscores the importance of analyzing and understanding our existing systems to drive meaningful change. And because 80% of health outcomes are socially determined, integrating social impact into your healthcare business strategy is essential. It's about looking beyond clinical care to address the systemic factors that truly drive results. A recent study found that nearly 44% of patients are non-adherent to at least one medication change made at hospital discharge. And this non-adherence is associated with a 35% higher risk of adverse events in the 30 days post-discharge. So while it seems like an individual behavior is creating these isolated incidents, it's actually a predictable cascade of failures built into our systems. That 2 a.m. emergency, it started weeks ago when we discharged a patient without ensuring that they could afford their medications. That preventable readmission, it began when our system assumed a patient had reliable transportation to follow-up appointments. The medication adherence failure, it was set in motion when we didn't confirm whether patients could navigate the complex pharmacy system. This ties directly back to the concept of quality improvement. If every system is perfectly designed to produce its outcomes, think about that multiplier effect rippling across your system. These hidden costs manifest in decreased patient satisfaction scores, negative organizational reputation, reduced community trust, staff burnout and turnover, and penalties under value-based care models. But here's where I see hope. I'll tell you about a fascinating pilot program in my own town of Phoenix, Arizona. They combined AI-driven predictive analytics with community health workers, and the result was a 28% reduction in ED visits and a 3-to-1 return on investment in just 18 months. What made this work is that they stopped treating prevention as a static program and started using the concept of dynamic prevention allocation. Think about this as real-time resource adjustment based on population needs and emerging risk factors. They weren't just preventing these crises, they were predicting and adapting to changing risks. And I'll show you exactly what this looks like in practice. Picture one of your high-risk patients with uncontrolled diabetes. In a traditional system, we'd wait until she shows up in crisis in the ED. But in this new model, here's what happens. The AI system flags the patient's profile because it notices certain patterns, like missing 2 primary care appointments, not refilling their insulin in 45 days, living in a zip code with limited pharmacy access. So instead of waiting for the crisis, the system automatically alerts a community health worker who then reaches out to the patient and discovers several interconnected issues. Maybe the patient's work schedule changed, making it hard to get to their normal pharmacy. Maybe they're rationing insulin because they can't afford the copays because the insurance changed. They're missing appointments because they lost their regular bus route to the clinic. Now, here's where this system comes in. So instead of just referring to the standard resources, the team adapts their approach in real time. Maybe they switch their pharmacy to closer to their workplace, or connect them to a medication assistance program, or arrange telehealth appointments that fit their new schedule, or provide rideshare vouchers for in-person visits. In this scenario, we may see about $600 in support services and coordination time, but the savings are exponential. They prevented what would have been multiple ED visits for diabetic crises, each costing thousands. Now, multiply this across hundreds of high-risk patients. That's how Phoenix saw their 28% reduction in ED visits. They were systematically identifying and addressing risk factors before they became emergencies. And for value-based contracts, this meant a lower cost of care, better quality metrics, improved patient satisfaction, reduced readmission rates, and higher performance payments. So if you want to implement a similar approach in your organization, this is how to get started. First, use those predictive analytics. Your data is already telling you where crises will happen. Look at the missed appointments, the medication gaps, the social risk factors. These are your early warning systems. Second, make your response dynamic. Adjust your resources based on what's happening now, not what happened last year. Static prevention programs are like fighting today's fires with last year's water pressure. Your resource allocation needs to shift as quickly as your patient's needs change. When your predictive tools flag a risk, your response system should activate immediately. On static programs or past data can leave gaps in your system. Real-time responses mean using up-to-date information to direct resources where they're needed the most. Third is measure everything, but measure what matters. Yes, you want to track the obvious metrics like the reduced ED visits and the readmissions, but also capture the multiplier effects. That's staff retention improvements, patient satisfaction increases, strengthen community trust, and value-based care. These indirect benefits directly impact your bottom line. Let's bring this full circle. Remember that your system is perfectly designed to create exactly the outcomes you're getting right now. That's quality improvement theory, and it's also a financial reality. Every system creates outcomes. The only question is whether you're designing the outcomes that will sustain your organization's future. I'm Christina. Join me next time.